want to open it up now to some questions from the audience.
Yes, is kidney cancer preventable? Is it mainly a lifestyle condition, or is it genetic, or what?
Both, yes. Yes, and both. So, is it preventable? We don't know how to prevent it. The risk factors, there are only a few known risk factors for kidney cancer. One is obesity, one is smoking, and one is family history. And you can't do anything about your genes, and smoking and obesity are both preventable. They're not huge risk factors though, like smoking and lung cancer or smoking and bladder cancer. So for the most part, it's, you can't have too much influence on the kidney cancer. As far as we know, I mean, maybe there are other lifestyle things that we just haven't been able to pinpoint.
What are some symptoms that you could look for? When we found out my dad had kidney cancer, there was absolutely no symptoms, so it was a big shocker.
Yeah.
So for the rest of my family, is there anything that I should watch for?
Yeah, it's, unfortunately, when symptoms occur, it's often a relatively advanced cancer. So, about 3/4 of patients don't have any symptoms. The symptoms, the classic symptoms are still the same: blood in the urine, pain in your side, and rarely you actually feel something, a palpable mass. But those are big tumors. Certainly blood in the urine always requires evaluation, and it often is not evaluated out in the community, so that's an important thing. But for the most part, it's asymptomatic.
You mentioned earlier in the presentation about chemotherapy. I thought there was no chemotherapy. Could you explain?
Targeted therapy is a form of chemotherapy.
Oh, I see. Okay.
I'm glad you picked up on that. I felt bad after I'd said it, but it's chemotherapy means that you are giving medications for whole body treatment. And traditional chemotherapy is what we call cytotoxic therapy, which are just these IV drugs that will kill any cell. And the target therapies are often pills. Only one of those 7 drugs is IV. They're often pills, and they're just a little more specific, but ultimately it's chemotherapy. Radiation has no role in kidney cancer, but as chemotherapy, that is important.
I have a question. I don't know anything about creatine in the blood. Could you explain that for me?
Creatinine, yeah. So creatinine is a measure of kidney function. It's actually a substance that is produced by just regular turnover of protein, especially muscle. So, but it's excreted in the kidney at a very constant rate, so that the level in your blood is also kept fairly constant, and it is an indirect measure of kidney function. The problem is that you have to lose about 50% of your kidney function before your creatinine really starts going up. So it's not going to detect early kidney damage, but it's the best thing we have. We tend to correct it for your gender, so male, female, your age, and your body weight with a calculation. And that gives us another number that we call the GFR, the glomerular filtration rate. And the normal for that happens to be 100. And the lower it is, the worse it is. So it's easy to describe that as a percentage. Since normal is 100, if yours is 30, it's like 30%. So.
You mentioned not very much usage of biopsies.
Yes.
I was under the impression that kidney cancer follows along a needle.
Yeah, extremely rarely. So that there are two sort of just old reasons why we don't do it that are not necessarily based in evidence. One is it's going to bleed. If you stick a needle in the kidney, it's going to bleed. And the other is you're going to get needle tract seeding, so tumor forming in the needle tract. Neither of them happens very often. Well, so seeding has, I don't think, ever been described, and bleeding is very rare. So those are not good reasons. The real reasons are just that that it's hard to do. It's hard to do well. So you often don't believe the result that you get if it doesn't show cancer. If it shows cancer, that's reliable. If it doesn't, it's unreliable. And so you're left doing the same thing anyway, so it's not worth the risk of doing the biopsy. That's changing. We're getting better at doing the biopsies, but it has to be really a dedicated team, so the same 1 or 2 radiologists doing it all the time, not just the radiologist who's covering biopsies that day. And it has to, they have to develop the expertise to do it. The other thing we also do differently is we take cores of tissue, so bigger pieces of tissue, not just little, what we call needle aspirations. That's made a big difference too.
You said that the reduced renal function can be related to cardiovascular disease. When they're diagnosed with cardiovascular disease, is there a way that they can tell it is from that reduced renal function, or has that just been a study that's shown that it just occurs?
It's it's an association. So it's a study. It's a population-based study with thousands of patients, and if you look at all the risk factors for heart disease, cardiovascular disease, and you correct for age and being male and smoking and all those bad things, then kidney function comes out as one of the, so poor kidney function comes out as a predictor of heart disease. But in any individual patient who has heart disease, it's hard to say, oh, this is because of your bad kidney function. The other thing is we take out kidneys for live donors for transplant. So we take healthy young adults, usually relatively young, and take a kidney and put it in, brother, sister, mom, dad, and tell them they don't need to worry about it. So there's a little bit of a contradiction there. Part of it is that those are young, healthy patients, and the other kidney can compensate to some degree. And usually kidney cancer is older patients with other medical problems, and the kidneys aren't completely normal to start with. So.
If you have kidney cancer on one kidney, is your probability of getting the same cancer in your other kidney, does it exist or does it exist?
It is a little bit higher than if you'd never had a kidney tumor before. So if you have one kidney tumor, your chance of having a second are a couple of percentage points. Whereas if you've never had kidney cancer before, the odds of getting kidney cancer are something like 5 in 10,000. So the odds are higher, but it's not a very high risk.
So assuming these new targeted therapies are mostly directed towards clear cell, how effective will they be, say, for transitional cell, that sort of thing?
So for transitional cell, not at all. Transitional cell is a different cancer. It's a bladder type cancer that can form the kidney, but there are papillary and chromophobe and these other types, and sarcomatoid, that these drugs don't work as well for. And that is just an unsolved problem. I mean, in general, we will often give a trial. Christian Holmesburg will give a trial with one of these drugs because we don't have other options. But those subtypes need drugs. It's hard to develop drugs for specific subtypes because there aren't that many patients with each subtype. But the really fascinating thing is kidney cancer is not only are the genetic mechanisms of clear cell known, the genetic changes of all the subtypes are known because there are family histories and syndromes with each subtype. So that is actually grounds for optimism that we'll figure something out based on what we know about the genetic changes.
Once a patient has started Sutent or treatment like that, how long after the patient's been on that treatment can doctors see if it's really making a difference or if they need to switch to another drug?
Yeah, that's a good question. It's not as straightforward as you might think. So you would, I think, as a patient starting on treatment, you would expect everything to melt away, and that's the proof that it's working. But with these drugs, and it was a lesson that was really learned with drugs like these in the last 10 years, it doesn't have to melt away. As long as it doesn't grow, that's all that counts. So stable disease has become a new term that we use to describe the fact that either the kidney in the tumor or wherever else it might be has not grown over time. So typically if you started a new drug, you would have a CAT scan 3 months later. And as long as things haven't gotten worse, that's good.
one of your slides that showed side effects and that just mentioned bleeding. What exactly does that mean?
Which one?
Bleeding.
One of the it said side effects, and then one of the things was
Right.
bleeding. So can you expand on that, or what that actually means?
Yeah, so you have a higher propensity to bleed. So whether you're having a procedure done or gastrointestinal bleed, so bleeding from your stomach or your colon, sort of the natural places where people bleed from, the risk is higher in patients on these drugs.
Long term, someone who has a stable GFR, 22%.
22?
Yeah, on a solitary kidney.
Mhm.
My husband was talking about he had half the kidney removed of the one kidney he had about a year ago, and he's stable now. So
Yeah.
long term, what can we watch for? What can you do to help keep that stable? I've been following his diet.
I think, am I out of the camera? Oh, okay. So that also is a very good question. I think the important thing there is to avoid further damage, right? So he wants to avoid any of the other diseases that cause kidney failure over time. So, optimal management of any high blood pressure, avoiding obesity, avoiding diabetes, those types of things. So ultimately, eating well and exercising will preserve his kidney function best. The kidney itself is not, there's no overuse syndrome that just because it's working hard, it's going to fail later. That doesn't necessarily happen. But as we get older, we tend to accumulate these problems such as high blood pressure that's bad for our kidneys. So, you'd anticipate if he's taking good care of himself that he'll have that similar function for a long time. The other thing to avoid are things like ibuprofen and NSAIDs, the anti-inflammatories that are bad for kidney function, and avoiding dehydration. So you should always be drinking enough. So there's a comment on for legislative flat tire. That was Stephen saying that airplane had a flat tire. Was there another question?
You mentioned that about 20 to 30% of the masses do turn out to be benign, and I was wondering, are there any advancements being made in increasing the accuracy of differentiating between benign masses and kidney cancer masses?
Yes, with needle biopsies. So that's one of the motivations to do needle biopsies, because we're getting so many of these small masses. And if we can determine with certainty that it's benign, we leave it alone. The problem is that they look identical on imaging, whether ultrasound, CT, or MRI. The things that we have to go by, they look the same. They even look fairly similar under the microscope. So it's not that surprising, that they look the same on imaging. You could theoretically do some kind of blood test looking at a panel of proteins to see if that's different in cancer versus non-cancer, but that panel is not yet known. So.
Can you just speak on managing long-term, kidney disease, or kidney cancer when do you use surgery?
When it comes back, or
yeah, when it comes back.
So it's another good question. It depends a little bit on the time course. In general, if we, for example, take out a kidney and we thought that it was limited to the kidney and there was no sign of any other disease, and the patient develops a spot in the lung, then we would want to remove that spot in the lung, which is something you wouldn't necessarily do with most cancers. If a patient comes back, though, and has 7 spots in the lungs, then that's too much too quickly, and we're never going to get ahead of that. If we go and do lung surgery, it's going to appear somewhere else before the patient's even recovered from the surgery. There are occasional patients where every 2 or 3 years we're doing a surgery to remove kidney cancer from, the thyroid, the lung, the bone, the pancreas. It just is a fairly, what we say, indolent course. So they appear slowly, they grow slowly. We remove it, the patient is fine for a few years, and then it appears somewhere else. And it's still worthwhile doing surgery even though we have these new drugs, because the new drugs don't work forever and they have side effects. So it's often better just to do a surgery to keep the patient off the drugs for longer and save them for another day. So it's still rare, but there are patients where we're doing multiple surgeries for recurrences. Often another twist to it is often we will give drugs. So a patient who presents with several metastases, maybe just a few more than we can deal with, 3 or 4 or something, give them one of the new targeted treatments, and sometimes the tumor will shrink at 3 spots but not the 4th. And so we'll remove that 4th spot because it looks like it's a trouble area.
As a homophobe survivor, I'm wondering if, as years go by, is there more evidence that if you had a solitary tumor, your chances of not having metastatic disease grows? Your chance of not having it?
I'm not sure if I understand. So
It's been a lot of years since I've had that surgery.
Yeah.
So I'm wondering if over those years there's more evidence that my chance of having a recurrence is smaller.
Yes,
than
so
originally
chromophobe.
thought.
Yeah, the chance of a recurrence with chromophobe is quite small.
Yeah.
I don't know, I'm not old enough to know what we thought 10 years ago, but I'm not sure, it's been recognized to be low risk for a while. The further out you are from your surgery, the lower the risk is of coming back. So the longer you go without any sign of anything, the better off you are.
I have a question for you.
Okay.
Okay. So what do you recommend for family members of a patient that has kidney cancer? So at what point would you recommend that family members might need to be looked at more closely?
Yeah, it's a tricky question. So there are the familial syndromes where patients get tumors when they're young and they get multiple tumors. And there are programs for that, hereditary kidney cancer programs in BC and other provinces with guidelines of when you should get an ultrasound or CT or whatever. And it's usually sort of after age 20, you get an ultrasound at specific intervals. But for most patients with kidney cancer, you're 50 or 65 or whatever age you might be, and you develop a small renal mass or even a more significant renal mass. We know that the offspring have a somewhat higher risk of having kidney cancer than somebody else just off the street, but it's not really high enough to be doing any routine imaging at regular intervals. It's something where you might ask your GP for an ultrasound at age 50 and again at age 60. There are no set guidelines for that.
Any other questions? One more.
Sorry, I don't know if this was in your introduction or if this was related, that I think you specialize with kidney, bladder, prostate, and testes, is that correct? And is there the relation between the kidney cancer and all of those?
No.
Or, no?
Those are just the urologic organs.
Okay. I just wanted, because I'm thinking, okay, thanks.
The kidney drains to the bladder, the bladder drains to the prostate. The testes hang down the nose.
I'm just thinking for women, you only got it too, so.
Yes. I'm sorry.
That was in the introduction.